Good afternoon, everyone, and thank you for joining us for today's webinar, Understanding the Value of Integrated Clinical Pharmacy Services to Improve Health Outcomes and Patient Safety. My name is Rachel Logan, the Training and Technical Assistance Manager at the National Center for Health and Public Housing. Today's webinar will focus on clinical pharmacy and will serve as a form of training and technical assistance that we offer to health center programs serving low-income populations as well as residents in public housing. We are supported in part by a grant from HRSA to provide this form of assistance. Our presenter today is Sandra Leals, a pharmacist and clinical director of pharmacy at El Rio Health Center in Tucson, Arizona. She also serves as the clinical director of the Broadway Clinic for Special Populations. Dr. Leal is a practicing clinician and in her administrative capacity is leading the integration of clinical pharmacy services in a large federally qualified health center. Her work has been to develop the role of pharmacists in new models of healthcare, including patient-centered medical homes and accountable care organizations. She currently serves as the National Chair for the Patient Safety and Clinical Pharmacy Services Collaborative to promote integration of clinical pharmacy services nationally to improve both health outcomes and patient safety. After today's webinar, attendees will have the tools to describe essential elements of patient safety and clinical pharmacy services PSPC collaborative. Also, summarize how integrated clinical pharmacy services into care teams can address systems barriers to optimal care delivery to patients. And they will also be able to apply the practices outlined by PSPC to address adherence, improve medical outcomes, and address medication related to adverse drug events. I would like to remind all attendees that the webinar will be recorded and made available on our website shortly after the end of the webinar, and will also be emailed to you with the resources that will be discussed today. I'll go ahead and turn the presentation over to Ms. Leal.
Great. Well, thank you very much for the introduction, and it's a great pleasure to be here speaking with the National Center for Health and Public Housing Group, and just a really a great honor to be speaking about clinical pharmacy services today. It's such a sometimes overlooked resource that's very, very widely available in the community and now in safety net organizations. So what I wanted to do today is really help you understand the value of integrating clinical pharmacy services to both improve health outcomes and patient safety. So I've been part of the Patient Safety Collaborative now for about 6 years. This collaborative has been going. It was initially funded through HRSA, and this is the Health Resources and Services Administration, which really offers a lot of grants to safety net and underserved populations and communities. So we've already had the objectives right there on the screen now, but let me go ahead and get started with a little bit of background about the Patient Safety Collaborative. Initially, when the Patient Safety Collaborative started 6 years ago, the aim was to commit to saving and enhancing thousands of lives by achieving optimal health outcomes and by eliminating adverse drug events through clinical pharmacy services. So the role of the pharmacist was really taken out of the dispensing mode, where I think a lot of people still think about the pharmacist in that capacity, which is very, very important, but really bringing them into a treatment team and then really working on relationships within the community so that people have a relationship inside the clinic walls, and then after they go home, when they have that prescription in hand, and they're having to take it every day, so really getting that involvement before the prescription is written, during the time the prescription is written, and really after the time the prescription is written. So the strategies of the Patient Safety Collaborative were many, but these are the 5 strategies that really came out of the collaborative right when it started. One of the nice things that the Patient Safety Collaborative did initially was it went out and surveyed practices that had already been integrating pharmacists into treatment teams and looked at what was allowing them to be successful in their practice. So if you're trying to replicate a similar model where you're at, these were the really significant strategies as part of this change package they developed so that we could replicate this model to multiple sites. So the biggest thing that came out of this is that you really needed leadership commitment, and I think that's key for a lot of different initiatives, not just this one, but really having organizational buy-in and having relationships that support this type of effort. Measurable improvements, very significant. I mean, for us, one of the critical factors in being able to spread the services that we started was by being able to share the impact of the outcomes that we were targeting, and then really shifting what we were doing to try to hit some of the new healthcare reform models, like showing impact in an accountable care organization, showing improvement in a patient-centered medical home. So we were really very, very aware of the importance of documenting our impact early on and then capturing our interventions and then making sure that we were following through on those. Integrated care delivery, this is very important. Everybody's talking right now about integrated care, about the importance of team-based care, about having the patient be part of the patient experience and having a good outcomes as a result of this integrated care delivery. So if having that framework and that infrastructure to start developing those teams was very, very critical for the successful practices to be able to replicate. And not just in a healthcare setting, but really being able to bridge that out into the community and having resources out in the community that support that. And so you've all probably heard about the transitions of care, how to have that communication from the hospital setting to the primary care provider to caregivers at home to the pharmacies out in the community. That was all something that we were very, very aware of and thinking about as we were developing these strategies. Safe medication use systems. Some of the most common reasons for people going into the emergency room are adverse drug events, errors that relate to medication use. So we were trying to show impact on reducing adverse drug events, especially in high-risk populations. And we know that high-risk populations are those populations that experience low health literacy, or people that are taking multiple medications, or people that are taking high-risk medications like anticoagulation medications such as warfarin, or medications such as insulin or oral hypoglycemics for people who have diabetes. So we see that these types of medications, or having a regimen of medications that's very complicated, can lead to medication errors resulting in ER visits or hospitalization. So we were targeting this specific area to reduce adverse drug events and hopefully reduce overall costs of the system, but most importantly, improve patient care. Now, the center of all of this is definitely the patient. So focusing on the patient, making sure that we were developing a system around the patient was very, very critical. So these strategies, when we looked at them and reflected on those successful sites that were having good impact, we were taking the best examples of these and then creating a change package to be able to share with other sites that wanted to join the collaborative. So a little bit of an update on where we're at with that. Since we started back 6 years ago, we have had over close to 450 teams across different safety net organizations that have replicated this type of model, with lots of partnerships, not just in the health center, but looking at other opportunities outside of the health centers, such as partnering with colleges of pharmacy, other colleges of nursing, other professional organizations. Here in Tucson, for example, we looked at opportunities to partner with our health department, with a PIMA Council on Aging, so different types of relationships that would really allow for us to be able to deliver care outside of just the care that we deliver in our clinic walls. So why we were really thinking about this is we really wanted to allocate the efforts of what we were doing. A lot of times when we look at the care that we're providing, we're allocating the resources at a very acute treatment and very end-stage care treatment that's very expensive. So the Patient Safety Collaborative really wanted to move the current treatment from rescue care or end-stage care to more of a primary prevention or secondary prevention and treatment. And so that focus really allows for us to move earlier in the treatment pathway versus really focusing on just those really acute critical patients. And I think a lot about this when I think about patients with diabetes. We have people with diabetes who come in who are very uncontrolled. Maybe they've had issues affording their medications, or maybe they haven't started insulin and they should have started insulin 5-10 years ago. What we're trying to do now is get in there earlier, really focus on educating people before they develop complications, and really trying to get them to target the primary care interventions much, much earlier on. So, making sure people go get their eyes examined with an ophthalmologist, making sure people are getting their foot exams. And here at the health center, we actually have the pharmacist doing the foot exam. And if you can imagine that, The pharmacist actually has a care visit with patients, and we're able to provide a lot of the standards of care for diabetes that really enhance the way we deliver care because we're doing it as a team. I always get asked the question, well, what about the doctors or the other providers like nurse practitioners or PAs? Do they have any issues with you taking over care? Well, my answer to that is that we don't take over care. We work in collaboration with the providers, and so we are actually able to enhance the comprehensiveness of the care that we deliver. And really, if you look at the current issue around access to care, a lot of our primary care providers are very overwhelmed, and we even see a lot of waiting time for patients to get in to see their primary care providers. So when we are able to provide care additionally to the providers, we're actually enhancing our ability to be able to make interventions much, much earlier and provide additional access, and then bring our expertise, which is bringing in that medication review aspect to review all the medication issues that might be occurring. So an innovative care model, integrating clinical pharmacy services into a treatment team, these are the things that we're really targeting, and before the prescription is written, during and after, we're really trying to improve prescribing. One of the things that we do, aside from seeing patients on a day-to-day and then working with our community pharmacies, is really trying to improve prescribing for all our providers. We do a lot of education, we do a lot of updates on guidelines, we make sure that we're checking for medication safety events or workflow issues that might be resulting in safety events and trying to target those before they continue to happen, like actually looking at workflow to address those issues. We really target trying to decrease those errors to improve patient safety and ultimately improve health outcomes. And just this morning, about 2 hours before this presentation, I actually gave a presentation to our staff here at El Rio Health Center, really talking about our ability to collect adverse drug event data in an ambulatory care setting so that we could proactively address any trends in our workflow that might be contributing to that. And surprisingly, we had a lot of good questions from the providers. They wanted to know how more they could document and participate in doing that versus, a lot of times I think it's overwhelming to try to do that as part of your visit, but I think when they see the value of doing that and how we're actually taking action, they can see that there is a definite benefit to the patient in doing that. So for us, this is a couple of patients and a couple of examples of visits that I have. If you can see the first picture with a lady and the young child, the medication bottles on the desk there represent a very usual patient for us. We see people that come in that are taking 10, 12, 13 medications plus insulin, and really trying to have somebody understand that can be very complicated, not to mention the fact that people might be having affordability issues or having a side effect from the medication. And here in Tucson, where I live, we actually live very close to the border. We live about an hour north of the Mexican border, and we see people bringing in medications from Mexico that they're obtaining there because it might be less expensive, or there might even be a product that is not approved in the United States that they bring in because they've heard about it. So we really try to work on reconciling that, making sure patients are understanding what the regimen is supposed to do for them, making sure that adherence is happening, and then most importantly, making sure the patient is having a good clinical outcome as a result of that. And sometimes it's actually taking away medications, not adding more medications, because we see that too many things could actually have interactions with themselves. When we see the patient, we're not in a pharmacy setting, we're in a clinic visit, and we're working with patients to log their blood sugars, really helping them understand what the patterns are, what they're trying to target. So it's a very, very comprehensive visit. And I've specifically seen patients for diabetes, but this type of intervention for clinical pharmacy integration can happen for any chronic disease state or any actual disease state that requires medications. So I always think about that as an opportunity because anytime you have medications, there's a potential to make an intervention that could be significantly impactful. These are the common types of drug therapy related problems that we see, and so these have been documented in a large group of patients that they were tracking these types of outcomes. So the most common thing that we see is the need for additional drug therapy. And so in here what we find is that a lot of times patients might be missing a critical medication that has been known or studied to prevent adverse outcomes. And I'll give you an example of that. That would be like somebody who's already had a heart attack or a stroke who might benefit from an aspirin a day, and they're not taking it because maybe they forgot, maybe they just didn't realize it was important. So that's one of the drug-related problems that we often see. Sometimes the dosage is too high or the dosage is too low, and so we need to assess that based on the patient's adherence and then monitoring different values that we're trying to target. We also check for adverse drug events, making sure patients are tolerating the medications well. Unnecessary drug therapy. We see this a lot when a person is maybe hospitalized for a short period of time and something might be started in the hospital, like a stomach acid reducer because they're in a stressful situation, but they get discharged and they're still taking it, months on end because nobody told them, hey, you don't need this anymore. This was just a hospital medication. And then there's always the issue of compliance or the need for a different medication. So all of these are potential or common therapy-related problems that we look at when we're really working with patients closely. These are other identified errors, and I just wanted to pull out a couple of examples here, but again, unnecessary drug therapy, ineffective drug, adverse drug events, non-adherence, and then some of the other issues that I think are very critical that sometimes get overlooked, but simple things. The patient cannot afford the drug product they're being prescribed. It's not on formulary, so the person goes to the pharmacy, they are told, oh, we need a PA. A lot of times patients don't know what is a PA. Well, it's a prior authorization, and so they don't realize they have to wait for that before they can come back and pick it up. Sometimes they just think, oh, I can't have it, and so they never come back for it. So a lot of that can actually lead to a rehospitalization if that was a critical medication they were needing. And other simple things like patients cannot swallow or administer the medication. They forget to take it because the regimen is too complicated. So when we're integrating clinical pharmacy services into these models, we're really looking at opportunities and thoroughly evaluating where we can make a difference with these types of interventions. So the medication therapy management is something that's very critical. Now Medicare Part D, actually, this is D like dog, they actually pay for Medicare medication therapy in some instances depending on the plans, and it's becoming more widely reimbursed for those patients that do happen to have health insurance. But some of this medication therapy management that allows for the pharmacist to participate in these more thorough reviews include, full pharmacotherapy consults, disease management or coaching support, other very more unique type of interventions like pharmacogenomics, looking to see if certain type of medication safety issues are happening with a patient. We're also really targeting health and wellness and public health interventions, and I think the best example of that is immunizations. With pharmacists now being able to immunize in 50 states, I believe it's 50 states now, the access to immunizations has become much, much more available, and people, they go to the grocery stores or going to pharmacies, and it's so much easier for them to get immunized versus having to schedule a separate visit to see their doctors. And most recently, there's been a push. It used to be that pharmacists could only immunize adults, but most recently, there's been legislation in a lot of states actually allowing pharmacists to immunize to a certain age. So here in Arizona, in 2010, we were able to immunize children as young as 6 years of age. So it's definitely state by state dependent, but that's allowing for a significant impact on our ability to be able to reach patients that might not have a medical home or that struggle to get in because they work or have other issues and barriers to care. PSPC, or the Patient Safety Collaborative, really aligns with a lot of national efforts and reform service delivery systems that are happening now. So, when you're thinking about this, should I participate? Is this going to be new work? Is this something that we can afford to do? This PSPC effort aligns with other national efforts that are already happening, and a lot of you are probably participating in already. I think about this with the patient-centered medical home push, or organizations that are now becoming accountable care organizations, or if you're trying to do strategies like improving medication adherence for Medicare star ratings. The PSPC effort allows for a lot of the same work that's being done there to really impact those national efforts and have a good outcome. So the coordinated care piece that I spoke about earlier really talks to the patient-centered medical home concept, identifying patient needs and being able to target adherence, improves the star ratings if you're able to develop that, and then creating learning opportunities. The nice thing about the Patient Safety Collaborative is that it's created a network of organizations that are trying these things out and then teaching others about what's been successful and what hasn't been successful, and really teaching others how to disseminate this information and then spread the information. And as an example, here at my particular site, when I started services 13 years ago, it started off with one pharmacist out in the treatment area working with patients with diabetes. Now we have 8 clinical pharmacists throughout our health center. We have a focus on pain management, diabetes, hypertension, cholesterol, and then most recently we started working on the Medicare annual wellness visits, so really moving to even more earlier on in prevention and targeting those comprehensive evaluations to prevent disease rather than just targeting people that are already having chronic conditions and who are ill. Another national effort that this PSPC aligns with is the Million Hearts campaign, and I'm not sure if you've heard about the Million Hearts campaign, but it is a CDC government effort to try to reduce heart attacks, 1 million heart attack reduction and stroke reduction by 2017, and they actually point out and talk about the providers that should participate in this. Of course, it's your physicians, nurses, but they specifically also talk about including pharmacists in that because they are the most accessible providers out in community pharmacies. The statistic is that about 300 million people go to a pharmacy every week. So that's pretty close to the entire population of the United States. And this is maybe because they're going into a retail facility like a Target, a Walmart, a Safeway, or another grocery store. So there is an opportunity to access a pharmacist there. So you're really having an ability to capture a wide audience if you think about it in those terms. But really the Million Hearts campaign was trying to prevent these very, very adverse, these terrible events, heart attacks and strokes, by education, teaching, coaching patients, but really looking at following medication treatments and improving adherence for some of those medications that have been known to reduce heart attacks and strokes, such as cholesterol medications and antiplatelet medications like aspirin. But really, again, focusing on the team-based care approach and then building collaborations within the community to be able to do that. Another example of this is the Partnership for Patients, which again is a public-private partnership, and it offers supports to physicians, nurses, and other clinicians, including pharmacists, to work in and out of the hospital. So the key with this is really targeting the medication use and safety because this is a very, very critical component. And so the PSPC, they've worked with different successful models of care to target some of these patient safety elements that are very critical. So like any effort that reduces hospital infections or readmissions to hospitals, or targeting transitions of care to prevent readmissions. You can think about it in terms of that, and so the Patient Safety Collaborative tries to address some of those efforts. Some of the other efforts that PSPC aligns with is the NCQA HEDIS goals. If you're an organization that's targeting these HEDIS goals around processes, making sure people are having their A1Cs monitored, and then making sure that they're under the 9%, or making sure that the blood pressure goals are targeting. And again, I mentioned CMS star ratings earlier, but the same types of efforts looking at making sure that patients are taking the medication that they should be taking, and then making sure that they're picking them up at the appropriate intervals. That's very, very much in line with the PSPC collaborative, and again the community care transitions and care program. So PSPC team efforts, if you're thinking, wow, this sounds like something that I could use to really enhance what I'm already doing, that's exactly what the collaborative is trying to really reinforce. Another national effort is the National Diabetes Education Program. This is a program with NIH and the CDC, and this is a really unique collaborative that's really working at what they call the PPOD, which is a collaboration or a team approach looking at professions that you don't usually think of that are very critical to care for patients with diabetes. And so the PPOD group is pharmacy, podiatry, optometry, and dentistry, and really engaging all of these providers who treat patients with diabetes to really reinforce the diabetes message across all of these different professions. So if a patient, for example, if they go to the optometrist and the optometrist realizes that they have diabetes, they would reinforce how important it is to have control of the diabetes, making sure the person is taking their medications, If they're going to the dentist, they would get that similar message. And so there's resources associated with this PPOD collaborative and this effort that's really, really nice to have. So I did include the source there and the website for you if you want to obtain some of these different resources that are available. But they've got different PowerPoint presentations. They've got some tips for communicating with patients, some resources, and some handouts that are very, very nice. And again, including members of the team that sometimes might be overlooked as being very critical in the care of people that you're working with. Another big effort that we've been part of is a Project Impact Diabetes. This is a diabetes intervention where the American Pharmacists Association Foundation looked at 25 highly underserved communities across the United States, and they looked for opportunities to integrate pharmacists in those underserved communities to deliver patient care related to diabetes and adherence and improving outcomes related to diabetes. So what I have here on the screen is the interim results, and these were this intervention occurred for a year, so we're actually currently evaluating the final outcomes. But in the initial review of the outcomes, we had over 1,500 patients that were enrolled, and so we were able to track the A1C reduction. We were looking at body mass index, systolic blood pressure, and LDL reduction. And so these are the values that are reported that showed a statistical improvement. So we saw a baseline A1C of 9% decrease to 8.3%. And again, this is the interim results. We're going to be publishing this data for the final results, and we're seeing trends that are even better than this. We saw a reduction in the body mass index, systolic blood pressure, and then the cholesterol, the LDL or the bad cholesterol, as a result of really integrating clinical pharmacists in these highly underserved areas. So the things I think about are that when you do this is you're adding another workforce that's sometimes overlooked. You're improving access to care, so you're allowing patients to be able to see another provider maybe more frequently than their usual provider, because if you think about it, if a person is having to go to the pharmacy to pick up medications, even if they have one medication that they pick up monthly, that might be up to 12 times per year that they might have an interaction with this individual. If they're picking up multiple medications and they have to go into the pharmacy 2 or 3 times a month, then you can see how much contact is potential and possible with this, with integrating the pharmacist as part of your treatment team. For us, we've actually been collecting data since 2000 to show the impact of our interventions to see what that has done to costs. And so the blue line represents El Rio Health Center and our pharmacist team and how we've been able to really stabilize the costs associated with the patients who have diabetes. The red line with the yellow dots, that represents a match, actually 2 match sites that had same demographics that experienced usual care. And so about 6 years post-interventions, you could see that the cost of care starts to exponentially increase. And so I think that has a lot to do with the control of diabetes. If you're able to maintain the A1C control, if you're able to hit the standards of care like eye exams, foot exams, prevent foot ulcers, things like that, you're hopefully going to be able to stabilize the cost of care so that they don't have high cost complications later. And so if you're having usual care and you're seeing the trend of the A1C continuously go up, we start seeing some of those very, very expensive complications after 5 years of not having control. It could be anywhere from 5 to 10 years, sometimes sooner, sometimes later. But we start seeing that patients who have had uncontrolled diabetes for that period of time start experiencing, deterioration of their kidneys. They might experience foot ulcers, they might experience vision problems, so then the cost of care starts to dramatically increase over time. And the latest statistics on the cost related to diabetes in 2012, it was estimated that it cost $245 billion to control patients or to manage people with diabetes. That's expensive, $245 billion with a B. So a lot of room for improvement on that. And as you all well know, and unfortunately we're seeing much more diabetes presenting to the clinic and much younger patients. So we're seeing complications associated with diabetes at an earlier age. Our program and this type of model that I'm describing was written up by the Institute of Medicine. They actually featured us in this document called Core Principles and Values of Effective Team-Based Healthcare, which I do have the citation for, but really it talked about the integration. At the time, we had 5 clinical pharmacists, and it sort of describes the team composition. So the pharmacy team had 5 clinical pharmacists. We also have pharmacy residents that we work with. And then the team consisted of the physicians, the nurse practitioners, the physician's assistants. We also emphasize heavily dental care. We have dental care here at our health center. We work with diabetes educators, and actually the pharmacists that we have are diabetes educators, so we have that dual recognition. We have nutrition counselors, behavioral health workers, mental health workers, nurses, and then we also include our administrative staff and our IT staff, because our IT staff has been very critical in being able to generate and produce the reports that we need to be able to document more of a population health management strategy versus just a one-to-one type of encounter. So that's been very critical for us to be able to show the impact of our services. Now we have close to 80,000 patients that we serve in our health center, and we've spread out the services of our pharmacists across the organization. So it used to be that we were co-located at one site. Now we have 8 different sites that we're trying to see patients at, so it really reduces the transportation barriers to come and see these members of the healthcare team. We definitely use electronic health records to be able to look at the population, look at what's happening to see if we're having quality report cards that are showing an impact in reducing patients who have elevated A1Cs, and then making sure we're following and meeting those really critical markers, like making sure patients have the kidneys screened when they need to at the appropriate interval, eye exams, the foot exams, and the vaccinations that are recommended for patients with diabetes. So I pulled this article from Forbes because this is a very recent article. If you look at the date, it's April 10th, 2014, but it's really starting to recognize the value of looking at pharmacy as a solution for some of the continuum of care outside of the clinic wall. So this is fixing healthcare can be as close as your neighborhood pharmacy, and it's really just talking about the expected or projected shortages of full-time physicians, and then really the expanding roles of pharmacists. So in over 47 states now, pharmacists have the ability to have some sort of collaborative practice agreement with providers to be able to provide education and then even medication adjustments or counseling, coaching, depending on the site that they're located. But there's true solutions there, and you just really have to look at the state scope of practice for your particular state to be able to understand whether or not you can really have those relationships built, and then use them as champions for medication adherence. I think that can happen in any type of setting, anywhere, if you try to build that relationship with your pharmacist. So one of the things I did want to mention is that the Patient Safety Collaborative started 6 years ago, and it was funded by HRSA, and it is now transitioning to more of a public-private relationship. It will no longer be funded by HRSA, but it will be picked up by this organization called AIMM, which is the Alliance for Integrated Medication Management. So the government-funded support for PSPC really served to launch this effort to create these different partnerships across the United States and to build these teams. And so now what we're trying to do is continue this work and make sure it doesn't end. So what AIMM is doing is they're actually going to continue to offer the same support that PSPC did. So they're doing a lot of the collaboration, the action learning networks, and really gathering people together to have an all teach, all learn type of environment where we really learn from each other and try not to reinvent the wheel, and look at different resources that we might be creating in one state that might be helpful in another state, and so on. But really, one of the nice things that AIMM will be offering is a capability for tracking, collecting, and reporting data outcomes for local, regional, and national performance stories. Right now, it's so critical to show the impact that you're having in whatever intervention you're making, and especially if you're in any type of healthcare reform environment where you're looking at accountable care. A lot of the third-party plans, accountable care organizations, the patient-centered medical home, they're looking for outcomes. To be very honest with you, I think for us, the reason we've been able to spread is because we've shown a significant reduction in A1Cs. We've been able to show that our interventions have made a reduction in costs, like I showed you in that previous slide. And so that tracking capability is very, very critical. So what they're going to try to offer with the AIMM taking over is really like a database for you to be able to collect your results and then The next step is to show what impact financially that's having to be able to build your return on investment, your ROI story, so you can, convince your administrators to have that leadership buy-in that you need to be able to do this work. So again, AIMM will offer a learning infrastructure. They're really going to work with organizations to help transform them, and then they're going to help you with understanding who you could collaborate. There might be a similar institution in your state that's already doing this work, so partnering you up with that. One of the nice things that AIMM did and the PSPC did is that they started involving quality improvement organizations across the state about 4 years into the Patient Safety Collaborative. So previous to that, we did not have a relationship with the quality improvement organizations, but as PSPC evolved, we saw a very nice partnership with the QIOs, or the quality improvement organizations, because there were so many similar targets that they were trying to achieve. And for the QIOs, their scope of work at the time was to reduce A1Cs in patients with diabetes, reduce adverse drug events, and really target patients who had anticoagulation to prevent some of those high-cost ER visits and some high-cost interventions. So a little bit more about AIMM and what they're doing is they're really going to try to decrease the number of potential adverse drug events. So it's really similar to PSPC. Almost the entire framework of it is staying very similar. It's just going to be that transition over. But again, community care transitions, focusing on readmission rates to decrease those, and then targeting decreased overall healthcare spending. What they do want to see an increase is patients with controlled chronic conditions. And so AIMM really allows organizations to pick their priorities. They're not specifically saying, you have to focus on diabetes or anything like that. What they do is they allow for you to pick your population of focus and your areas of priority, and then try to identify ways to be able to document that you're controlling these people. So we've had teams in the past that have participated who are targeting pain, asthma, HIV, again, diabetes, but so many different opportunities there. We're focusing on increasing patient engagement and satisfaction, again, a very, very critical element in some of the Medicare reimbursement strategies, and then alignment with national measures. So not replicate or not duplicating work, but really aligning with the work that's already having to happen in order for you to hit these markers. So this is kind of the structure of how it's happening here. It's going to be a structure that's highly flexible, cohort-based action learning network, but really just talking about what I already mentioned, really looking at cohorts of patients and teams and sharing information within organizations, and then bringing teams together so that they have impact in a national way to show the impact that they're having. So this is to build that case for recognition of this type of effort to be able to continue to do this work and spread the work. So a little bit more about the quality improvement organizations, because they're also changing. So they've been in the 10th scope of work, but starting in August, they're going to start their 11th scope of work. And so what's historically happened is that there's been a quality improvement organization in each state that has focused on targeting different outcomes that their scope of work requires. So like I mentioned before, in the last scope of work, it was reducing adverse drug events, targeting patients with diabetes, and people with anticoagulation and psychiatric medications. The scope of work for the 11th scope of work is changing a little bit in that they're actually going to reduce the number of QIOs that CMS contracts with. So it's going to be reduced to, instead of one per state, they're going to do more regional QIOs. So there's going to be about 5 or 6 regions that you could work with depending on the state you reside, but there will still be an alignment to try to improve the care of Medicare beneficiaries and, again, align with a lot of the national quality strategies as CMS quality strategies to be able to have improved outcomes. Another partner that I think about if you're a safety net organization that qualifies for the 340B drug pricing program is Apexis, which is the prime vendor for the 340B drug pricing program. What they're trying to do is really educate people about the 340B program. They offer a program called the 340B University, which is free, and it allows safety net organizations to send representatives from their organization to understand the program, to understand how important it is, the integrity of the program, avoid diversion, but then also look at if you're managing that program well, how you can take some of the benefits of the program and invest them in some of these additional services that you're wanting to provide that might not be reimbursed. So It allows for you to increase services that might cost your center money, but that are very critical in improving the outcomes of the patients that you're serving. So I think the Prime Vendor is another very good resource that's available to any 340B stakeholder out there. This is the estimated QIO funding in the 11th scope of work. They're really going to target millions of dollars really to these different elements. So I have them listed here. So $159 million to healthy people, healthy communities. So there's a lot of focus on really engaging the community. They're looking at patient-centered, reliable, accessible, and safe care, better care, and lower costs. Technical assistance, they've been really helpful with us, the QIO, in allowing our communities and our healthcare providers to achieve meaningful use 2 and then meaningful use 3 stages by helping with IT assistance. So again, a resource that's available and already funded. You don't have to pay for it. You just have to partner with them and let them know that you're interested in this support. And then some other things that are very important: value-based purchasing support, contracts and quality measures, beneficiary and family-centered care, and other supports and staff. So the QIO, if you look at some of the opportunities that they have listed that they're targeting for the 2014 to 2018 cycle, there's probably things that you can really partner with and benefit from that would be, it would be mutually beneficial for them and it would be mutually beneficial for your organization, but then more important, trying to achieve improved outcomes, patient-centered outcomes that are reliable, accessible, and safe for the people that you're working with. So in summary, what I wanted to share is the Patient Safety Collaborative really has offered a very, very collaborative, integrated model for the last 6 years that's going to continue in this new form that's called AIMM. It's going to be the Alliance for Integrated Medication Management, but really the focus is to integrate and coordinate care, decrease barriers to access for patients, improve adherence, and then identify drug-related problems far beyond the clinic walls. The partnerships are very, very critical in expanding resources beyond the care here, but then looking outside in the community and seeing who are partners that you can work with that will help deliver care when you're not able to locally. So this is one of the things that's really, really nice about this model. And again, like you saw in the different sites, there's so many similar national efforts going on that this is really going to enhance what you're probably already doing. I just wanted to mention this website. It's www.rxprescribingpearls.com. It was a website that was developed by our clinical pharmacy group here at El Rio Health Center, just as an example of something that we've done to really try to get information out to our providers and then also to our patients. This website, and it's accessible, you can all go to it. It's open, it's free, but it does updates on different things that are very important, like the recent guideline changes for blood pressure, diabetes. There's diabetes handouts that are appropriate for low health literacy that are in English and Spanish. So each of those little tabs represents information that's available that we are trying to consolidate in one area. When we have a clinician or a provider or a patient right in front of you, sometimes you can't look, for that piece of paper or for that that website because you can't remember what it is. So this is just a resource that we created to try to consolidate that information. And so one of the things we did here is, we listed things like local classes and support groups for our patients, so that if a provider wanted to make a recommendation, they could quickly click on that and it would bring up what's available in the community. So with that, let me see if I can pull this up really quick. This is the actual live website here. Here's the local classes and support group. These are, it'll just show you the American Diabetes Association. I'm in Tucson, so we have the Tucson calendar up, but then we could quickly make a recommendation about what's available, what classes are offered, what's in English and Spanish, and really, allow for other things to be offered to the patient that can help support them once they leave the clinic. So thank you very much for participating today in this webinar. What we'll do now is we'll go ahead and take any questions that you might have.
Okay, thank you so much, Sandra, for sharing all that information with us about promoting clinical pharmacy services in the primary care setting. That's very important, very relevant now as HRSA is going to fund additional expansion grants for, the integration of behavioral health services, pharmacy services, optometry services, and making sure that the safety net Safety net health centers are prepared to address all of the needs of patients, including, prescriptions and things like that. So very pertinent information as we prepare for additional funding opportunities. So definitely thank you. If you would like to ask a question, please type it into the chat box that you should see to the right in the GoToMeeting toolbox, and we can get those questions forwarded to Ms. Leal. In the meantime, while I'm waiting for some questions to develop in the queue, I just have a few short announcements. Visit our website to get more updates and information on webinars, on upcoming webinars, as well as our archive webinars and other resources that we provide and post regularly to our website. Join our mailing list in order to receive HRSA updates, which also includes some of the things Ms. Leo mentioned with changes to recommendations and such. We provide those information in our weekly digest as well as throughout the website. So join our mailing list to get those updates of when we provide information and funding opportunities. Join us on social media at our Twitter, and also check out all of our YouTube videos on our YouTube channel. You can subscribe to our channel as well, and that's where we store all of our archived webinars. So if you get the subscription to YouTube, then you can just go straight there and look at everything we upload. Also, we have our upcoming symposium, June 10th through 12th in Alexandria, Virginia, and that will focus on a lot of the key issues and elements that we discussed here with integration of additional services beyond your traditional services that are offered at health centers, including behavioral health services, pharmacy, and all those various aspects. And of course, feel free to contact us. The staff here are open to questions and any form of assistance or any way we can assist you. Please let us know and feel free to contact us. So I'll go ahead and open up the Q&A portion. The first question is, how can health centers join the collaborative?
So right now, the best way to join the collaborative, because it is transitioning on July 1st, is to go to the Alliance for Integrated Medication Management website. It's called, the URL is medsmatter.org. So it's medsmatters.org, so medsmatter.org, and that will take you to the Alliance for Integrated Medication Management website. And so there will be information posted there about how to join the collaborative for the next round, because it's a continuous, so you can join year-round, so there's not a start or stop date. It's a continuous enrollment, and that will give you the information that you need in order to be able to sign up your team and be able to get some of those resources that I spoke about. The website also has a location finder for current sites in your state, so you could go to your state and see who's already participating, because another way to join is to join somebody who's already a team. You can actually collaborate with them and do we have a multi-site team in Arizona where we have 5 different organizations together, so you don't have to join independently. You can join as a group or you can join independently, so there's different options there.
Okay, great. And speaking of teams and the collaborative, how can individuals access the information that's collected at the various sites? Is it open to the public, or do people have to wait for the publication to come out?
So the way they've structured it historically is that the sites report outcomes nationally. So there's an aggregate group of information that's being reported nationally, and that's being reported to CMS and to other like HRSA and other institutions, and then also to the QIOs. But then the information you're collecting is actually local to your site. So you're able to use that information that you're tracking internally. So like for us, for example, I've used our internal outcomes for the population of focus that we were targeting for the PSPC to leverage local contracts, to leverage local positions here, and then sharing my sites on a national scale to be able to leverage more of the, some of the either grants or some other types of reimbursement that we needed on a national level. And then so they have what they call a national performance story that they publish. It's been usually every year after the year of the collaborative for that year, and they compile what they call the national performance story. And so you can use that and say, you know, we were one of the teams that participated here, and leverage that to, you know, whatever you need to use it for, either locally or within your state or nationally.
Great. And for health centers who want to begin adding pharmacy services, what are some of the things that they should be aware of when they take this task on?
So there's several ways to do that. If you have a pharmacy, so it depends on whether or not you have in-house pharmacy services or not. You know, people are doing this with or without pharmacies in-house, but there are ways to partner with colleges of pharmacy. I think that would be a good strategy if you didn't have pharmacists in your facility already, would be to partner with a local pharmacy college if there's one close by, or even within your state, because they're always looking for opportunities to have students or residents come out and start services. They also are looking for opportunities to place some of their clinical faculty staff at your site to be able to develop some of these services. So as an example, one of our positions here is actually funded in portion by the University of Arizona, and so they end up placing a person here at our health center, and then we have students that are workforce that's basically free, because they come and we have them do a lot of our medication reviews, quality improvement projects, things that we know would benefit our patients, because they're learning, and we're also, you know, able to use this workforce that's trying to have these opportunities. So I think a good place is to partner up with colleges of pharmacies if you don't have a pharmacist already in your system. If you do, what would be good if you have a pharmacist in your system is talk to them about it, see if they already know that the Patient Safety Collaborative is out there, or have them find out more information, or talk with your local quality improvement organization, because the QIOs in the state have been working with the Patient Safety Collaborative, so they could direct you to maybe another team or resources that would be able to help you get started.
Okay, great. And speaking of partnerships, how crucial is it to have a partnership with your local emergency department?
I think it's very important, but sometimes it can be difficult. You know, I think that's the key thing, and depending on where you're at, you know, there might be 6 emergency rooms. So I would say if you have a relationship with somebody there, that's great. That's a good place to start. If you don't have any relationships, it's really important to try to start forging at least one relationship. And that's when we started doing our transitions of care program. We started off with one hospital, documenting our impact on that transitions of care and reducing hospital readmissions as a result of adverse drug events and other interventions that we were doing. And based on those outcomes, we were able to share with some of the other local hospitals who were really impressed by the data that we were sharing with them. And so slowly over time, we've been able to spread that transitions of care program to the other hospitals across our organization, across our city. So I would say if you have a relationship with one, that's a good place to start. And then I think with the information you're collecting, the data, and if you're making an impact, that's definitely going to be very helpful. If you're part of an accountable care organization, you might already be part of a relationship with a hospital, and so you're mostly going to be focusing on how do you get the data about which patients are being discharged. You know, there are codes now that pay for transitional care, the transitional care management codes, so there are ways now to get some funding to be able to do that work, where before there wasn't that opportunity. So I think there's definitely the payment structure is starting to follow to be able to support some of these services that were not there before.
Thank you. Also, another question is, how do you change the culture at your health center to integrate members or pharmacists as members, primary members of the care team?
You know, I think that's a very good question, because we get asked that quite a bit. And, you know, initially when we started, and this was 13 years ago, there was some pushback. People didn't really understand the role that we could play in more in a care team versus, you know, what they thought of as us working in a pharmacy. But I think it's like any other relationship. Once you start doing the work, once you start documenting and showing what you're doing, and actually once the patients start reporting back to their providers about the visit that they had and how much they appreciate that, it slowly starts to build in buy-in. And so it gets easier and easier, and pretty soon you're going to be overwhelmed with referrals and visits. So the way I started is I asked for volunteer volunteer referral. So it was on a volunteer basis. I asked providers to send me their most complicated patients with lots of pharmacy issues or adherence issues. And then I said, let me try my interventions, and if you like the service, if you like what I'm doing, then you can send more. And guess what? Too many. Now we have too many. We're trying to keep up with a volume of referrals, but we definitely didn't make it a mandatory thing. It was definitely a collaborative effort, and then we specifically targeted their more complicated patients, the patients that were taking a lot of time for them, that they were not feeling like they were having success with, and for us to take those patients on, they actually appreciated that. So definitely all about how you present what you're trying to do, and then the benefit that comes from that. I think that's what sells it afterwards.
Great. And speaking of the training pharmacists receive, do your pharmacists go through any type of additional training to prepare them for this different model of care?
So most of the pharmacists that I have hired here, not all of them, but most of them have a residency, which is an additional clinical year, or they can do additional certifications. So for example, I mentioned earlier that some of them are certified diabetes educators, which requires 1,000 care hours with patients with diabetes and then a board examination. So once you have an area or a population of focus that you want to have the pharmacist interested in, there are special additional training programs that they can seek. They don't necessarily have to start with that right off the bat, but then, over time, it's nice if they get those certifications because they allow for provider buy-in and for patients to understand that they're going to, somebody who's specializing in these areas. And then there's for immunization, pharmacists do have to have a separate certification for immunization where they get trained to do the immunization appropriately and with the right types of populations based on pediatrics or adults. So there are now specialty certificates or residency programs that will do that additional training that might be required.
Okay, excellent. And the last question, are there any additional funding opportunities to integrate pharmacy services at the health center?
There are several different ways that we've been able to actually get reimbursed for what we're doing. So right now we became an accredited diabetes self-management education site, and so we are able to bill for our diabetes self-management training. So any visit that we see for that, we can actually submit a bill to Medicare or to the third-party plans that reimburse for that service. We've also been looking at the Medicare annual wellness visits, which are another, it's a G code that you can bill to do those preventative care visits. So you would utilize a pharmacist to provide those visits to be able to do that work. The transitional care management codes have to be billed by a physician, but they actually compensate for the team and the team effort. And there's a component of the TCM codes that requires medication reconciliation. So when we use a pharmacist to do that, part of that reimbursement for the TCM codes does get credited to the pharmacist for being able to perform that function. Other strategies that we've used are working on the shared revenue when we're hitting quality outcomes. With our ACO, they're targeting A1C reductions, different quality markers that we're hitting, and so if we're able to reach those goals, then we have a shared revenue that we are able to have attribution for and be able to fund some of these services. And then the final thing that we utilize that's been very effective is that we manage better prescribing. So when we're having patients utilize our pharmacy services, when we do manage our formulary, and when we have the 340B program and we're using it effectively and efficiently, then we're able to offset some of the costs if we're able to maximize our impact on that. So there's several different strategies to be able to do this successfully.
Wow, that is very informative, and I really appreciate the information that you have shared with us today. It is an exciting time to be a part of the safety net as we see these different models of care being played out on the local levels, and then even in a collaborative effort such as the PSPC. So as I would like to remind everyone that this session is recorded and the slides and resources will be provided to every registrant after the after the webinar, as well as posted to our website shortly thereafter. So thank you so much, Ms. Leal, for joining us today and presenting this information, and have a good afternoon.
Thank you.
All right, bye.
Bye.